Welcome, everybody. My name is Dr. Galimberti. I'm a gynecologist working in the community, and tonight I'm interviewing Dr. Louise Kelly. Louise is a consultant surgeon, and she's a breast specialist working in breast cancer treatment at Cork University Hospital. She's a long-term friend of mine, and she's agreed to come and talk to us about HRT and breast cancer. The reason why I wanted to interview Louise is because I'm a little bit concerned when I hear and read information that is being circulating on social media at present. HRT has been in the media quite a lot, and in one way this is a very good thing because a lot of women are asking questions, a lot of women are coming forward with their symptoms, but on the other hand it has brought in light a bit of misinformation that is given to patients. So there are experts popping up from everywhere and they're all advising patients, and from my end what I see is patients coming into the surgery telling me things like, oh, I heard that HRT doesn't give breast cancer anymore and it's 100% safe, which is not true. Or I've had breast cancer and I believe now I can take HRT as well because that's allowed now. So it's very confusing for some patients, I understand, but there are some very clear medical information that we need to give to patients, and that's what Dr. Kelly is going to do for us tonight. So, Louise, my first question is, can you please clarify for us what is the risk of developing breast cancer when you're taking HRT?
Well, Rita, thanks very much for asking me to be part of this conversation. HRT does not come with zero risk of developing breast cancer, but it is a lot lower than previously thought. So if we were to look at 1,000 women of the ages of 50 to 59, who would be the usual patient population who'd be looking to use HRT, well, we can expect 23 women of this 1,000 to develop breast cancer. The effect of HRT adds another 4 women to this group. But if we put it in context, the effect of smoking would add another 3 women, the effect of alcohol would add another 5, and obesity has a huge impact. That would add another 23 women. And on the good side of things, women who exercise frequently, who do more than 2.5 hours of exercise a week, they can reduce their risk and take 7 women out of that 23. So I hope that makes it a little bit clearer that breast cancer risk is not zero with HRT, but it's certainly not as high as was previously reported.
That's great, Louise. That's really clear. And that's what we tell patients, because for each patient, we tell them there's always a balance between risk and benefit to be done, which is different for each individual. And that's what the discussion about HRT is about. We want them to come in and ask about it, but we want them to understand that nothing is free of risk ever, really, in medicine and in life. So in relation to making different choices for different patients, can you tell me what is the situation when you have a family history? People get very confused about having a family history and putting everything together in the same pot when there's been few people who have had cancer. So where do these patients fit, and which one are the patients that are more at risk because they have a positive family history?
Okay, so family history is one of the risk factors that patients are very much aware of. And we run specialist family history clinics for our patient population, and we're really interested in first degree relatives. So they're mothers, sisters, daughters. We do take into consideration second degree relatives. But up and until you have a diagnosis of breast cancer, it is appropriate to have the conversation about HRT. It is, as you say, dependent on each person's comfort with risk, and everybody is comfortable with a different level of risk. So for us, risk is not just family history, it's also what age you are when you start menstruating, how old you are when you have your first baby, and then also I think the patient population who are most concerned are those who are genetic carriers. So people would understand about BRCA genes. Angelina Jolie has brought that into the spotlight very well. So BRCA gene carriers are women who have an increased risk of breast and ovarian cancer because of an inherited mutation. But even this patient population, Rita, we are actually comfortable with them having HRT once they've had their risk reduction surgery. So that is bilateral oophorectomy, bilateral fallopian tube removal, and bilateral mastectomy, so having both breasts off. So women who complete that risk reduction surgery, we're very comfortable with them taking HRT. And this is a patient population who often needs to have surgery at an early stage. So they would be women who'd been prone to the poorer outcomes from early menopause. Now, HRT is just one tool in the toolbox. There are other medications that can also be used. So, for women who are very risk adverse, we can use calcium and bisphosphonates for the osteoporosis. There are other ways around symptoms, but it is not to say that these people are disqualified because of their family history or their genetic history from having that conversation.
And can I ask you, Louise, how do they decide if they should be tested or not? How does one go about if they have a family history and they say, well, I want to know if I have the gene, how you decide if I should be tested, and where do these people go?
So some of the patients will come to us already knowing that a family member has been diagnosed with a mutation, and they have that information and they want to be assessed for their own risk. And we refer to genetics in Dublin, to be fair. Um, we're always keen to test the person in the family who has the breast cancer, because if we are going to find a mutation, it's going to be in those people that we find it. And then if they have a mutation, testing is opened up to the rest of the family. But if they don't have a mutation, then there's no need to test the rest of the family. But it often happens in my clinic that somebody will come in with a family history and they will request testing for themselves, though they have no personal history of breast cancer. And that isn't the way genetic testing works in this country at this time. Now, some people will choose to go and get a commercially available genetics kit and do their own testing, but we do not do any risk reduction surgery based on that result. We don't do increased screening necessarily based on that result. It's really important to have the counselling that goes with a proper genetics assessment, because this is information that is very complicated. On the one hand, a patient might have a positive result, meaning that they have a mutation, then they can consider risk reduction surgery, and it's risk reduction, not risk eliminating. So it is still possible to get a breast cancer despite having all that surgery done. They can consider increased screening. So before the age of 50, annual mammography and MRI scan, and after the age of 50, an annual mammogram. But they have to be comfortable with that level of screening. Um, and then, those patients who have a negative result, well, that's fantastic. They are population risk. But there's a group in the middle that may have a result that's of unknown significance. It's not positive. It's not negative. It's very much a head wreck. And it's not something you want to find out without having the appropriate support to deal with that answer.
Yeah, that's really important. It's not just something that you do yourself. When things become commercially available, they're very attractive, and patients might think, "Oh, I go and do it myself because they're not doing it for me," and they don't realize that they might do more harm in trying to get that information themselves than in actually left it to the expert like yourself. So we do really encourage patients to come and get proper advice in this situation as well. Just because something is available, you can pay for it, doesn't mean it's a good idea, isn't it?
Absolutely. And I suppose the other thing is for patients who are looking for a genetic referral, it doesn't have to come through the specialist family history breast clinic. It can come from GPs and the community as well. So there are many ways into the system, but it is really useful to engage properly with the system.
Thanks very much, Liz. That's really clear. One, obviously, the patients group that I'm more worried about is the patients who have had breast cancer themselves. For the people who follow me and know me, everybody knows that I'm very pro HRT. I prescribe it a lot, but that's the one situation where I don't. And so I would like you to clarify for us what is the situation with patients requesting HRT who have had breast cancer themselves.
Okay, so to be very clear, I don't advocate HRT, systemic HRT, for any of my breast cancer patients. And I know it sounds very harsh. And I suppose it's also worth disclosing that I don't prescribe HRT. It's not part of my scope of practice, but I am involved in the conversation about risk. The majority of breast cancer patients will have estrogen receptor and progesterone receptor positive disease. So this means their cancer cells have expressed estrogen receptors, and that those receptors will bind with our own estrogen to help cells divide and grow. And part of our treatments for breast cancer, besides surgery, the medical part of it is blocking those receptors. So we block those receptors by using anti-estrogen medication. And that puts patients into a chemical menopause, really. So why would we give estrogen as HRT to these patients? We are going to increase their risk. And they are not a population risk, because your biggest risk of getting a breast cancer is your own personal risk of having had breast cancer. So it's not sensible to increase risk for those patients. And then there are another group of patients that have what we call triple negative disease. So, sometimes people say, well, why are you so harsh? You won't advocate for patients with triple negative disease. Well, triple negative meaning that there are no estrogen, progesterone, or HER2 receptors, which is another protein that we look at. Now, this group of patients, their cancer is not fed by estrogen, so you would think, oh, well, it should be safe. But triple negative disease is considered an aggressive form of breast cancer. So in the first few years after their chemotherapy, we wouldn't want to be adding in a potential risk. Breast cancer. So I talk a lot about food in my practice, Rita. I'm all about the food. Breast cancer is a bit like pizza. You can have margarita, you can have pepperoni, you can have chicken, you can even have ham and pineapple, though it might cause some heart attacks in Italy. But they're all pizza. Breast cancer is not all the same. And unfortunately, some people will recur with a breast cancer that is estrogen receptor positive. So they might have had triple negative disease, but a recurrence might not be exactly the same. So those patients, that is probably the area where the conversation about HRT will take off initially in breast cancer patients, because those patients should or could be safe to take treatment. But it depends on patients' comfort with the level of risk that they're taking. And it would also be time dependent, because those first few years of treatment after triple negative disease are vital. And you wouldn't want to be confounding the issue by adding in HRT at that point in time. But maybe perhaps years later. And, it's so exciting that we're having this conversation about survivorship, because now our patients are living long and they have symptoms, and we want to improve their quality of life, but we want to do it safely.
And can I ask you, when you were talking about a different type of cancer, what is the situation with patients who have the in situ cancer?
Yeah. So in situ disease, thankfully, cannot kill us. It hasn't spread anywhere. It doesn't move around. It's not a situation where chemotherapy is required. But in the chat about recurrence, half of the people who get recurrence after in situ disease will actually get an invasive recurrence. So again, with estrogen receptor positive in situ disease, I wouldn't be advocating HRT for those patients. And in estrogen and progesterone receptor negative in situ disease, ductal carcinoma in situ, that's ERPR negative. Well, that is also an area where this conversation will take off in the future as more data comes through. But at the moment, it's not part of my practice to advise HRT for any of these patients. You know what it's like, Rita, when you've sat in the clinic with somebody, you've diagnosed them, it's been devastating. They get through that cancer journey. Why am I going to advocate for something that may increase their risk of recurrence? It just doesn't make sense to me right at the moment. Now, with changing preparations, changing duration, that conversation may take off, but at the moment, we're just not quite there. And that's not to take away from the people who are very debilitated from their symptoms and who are willing to take the risk, knowing that HRT may increase their chance of recurrence. Recurrence isn't necessarily in the breast. If recurrence happens in the breast, we would expect that for the majority of patients, that's curable disease and we can tackle it again. But if recurrence happens outside of the breast, in liver, lung, or bone, that's not then curable disease.
I
That's a
understand.
very different conversation.
Yeah. So there's many factors. So again, I suppose the message is not to believe it's completely fine. There are some very small situations where it can be fine, and some situation where it's not. And Louise, you made a very great point when you said about patients living longer. This is really fantastic news, because you're right, they live longer. So we actually have to deal with the long-term problem of health in patients who are breast cancer survivor. And one of the problems that they have is the vaginal atrophy, vaginal dryness, problem having sex. What's the situation with prescription of vaginal estrogen in these patients?
Well, thankfully, this is an area where the guidelines have recently changed, and we are now comfortable to prescribe vaginal estrogens for patients. We, as the clinicians who deal with breast cancer, appreciate that that's not zero risk either, but it's so much lower risk than systemic therapy. And as one of the tools that patients can use for vaginal health, it is very useful. So we would like as short a course as possible to relieve symptoms, but it is something that we have become comfortable with, but only quite recently. So a lot of women would have been advised against using vaginal estrogens before, and now that's changing. But there are other tools as well.
Yeah, and that's a topic very close to my heart because sometimes patients who have had breast cancer and have vaginal symptoms don't think that there is a treatment available. So we just want to make that very, very clear. Vaginal atrophy, which is a very, very stressful symptom for a lot of patients, is completely treatable. There's lots of ways to treat it. We have products we can use to make sex more comfortable. We can use vaginal estrogen long term. And now we have a new tool in treatment of this, which is vaginal laser. And interesting, all the studies on treatment of vaginal atrophy and laser have been done in patients population who had breast cancer because years ago we didn't give them vaginal estrogens. So they were the group where you could study the laser. But now we do both. We do the laser and we use vaginal estrogen as well. So it's good that that has changed. And hopefully with time other things will change as well.
Well,
Uh,
no doubt it's a huge improvement in quality of life, and like a lot of people lose their libido during breast cancer treatment, and then to have painful sex on top of that. So when you are in the mood, it's really sore. Like, that's not quality of life at all. And a lot of our patients are young women, and they should be active for much longer than, the the general media would let you believe that that's possible. So anything that improves quality of life, I think, we have to embrace. So we are thankful at the moment that these guidelines have changed, and we are much more open to suggesting to women that maybe that might help somewhat. And when you're feeling good down below, the
Life
horizon
can be
is a little
better.
bit brighter. Yes, absolutely.
Louise, thanks very much. That was very clear and very informative. Thanks again for joining me to have this clarification in this interview, and I hope that everybody found it useful and that there's some good quality information there for all their patients.
It's always good to talk, Rita. Thanks very much.
Thanks, Louise.